So welcome back, everybody. After this break, now we were listening to the presentation of results from 4 work package, and we will begin with the work package 5, Anders Theuenborg, Serdan Golubovits, and Sarah Henshaw-Blomqvist. Please.
Hello, everybody.
Hello, we can hear you and we can see perfectly your screen.
Super. Okay, so our colleague from Denmark, Hanne Dorte Emborg, will share the screen. I will talk first about a little bit about the interoperability of European IS systems, and then the presentation will follow with, as I said, a colleague from Denmark, Hanne Dorte, and she will talk about the cross-border vaccine coverage assessment, followed by Sarah Henshaw-Blomqvist from Sweden, who will talk about the cross-border campaigns. When we talk about the interoperability, this is the first work that we have done, and in the meantime, the COVID happened, so our data is pretty much not so good, because a lot of things have happened in the meantime, especially regarding the interoperability and most likely the development of IIS systems in Europe. So for the interoperability part, we are going to do a very short introduction, followed by the presentation for cross-border vaccine coverage, and then we will present the work in progress with main functionalities basically done, the development pilot platform for cross-border vaccine coverage assessment, and then we will end with our colleague from Sweden. So basically, just a very, very short introduction. The main idea of interoperability is to allow exchange of information and services among administrative entities, citizens, and businesses. Name exchange information has to be understood by all parties, and therefore interoperability initiatives should be driven by a specific business case. Interoperability is done through quite a detailed number of steps, but the main 4 are the 4 layers of interoperability. It is the legal interoperability, organizational interoperability, semantic interoperability, and technical. Legal interoperability deals with interoperability checks in a legal sense, basically screening the legislation to identify interoperability barriers. Organizational interoperability aligns the business processes, responsibilities, and expectations to achieve commonly agreed goal, and meets the requirements of the user community by making the services available, easy identifiable, accessible, and user-focused. Semantic interoperability deals with information that is being exchanged, basically falling under the umbrella of what is sent is what is understood. It is split into 2 parts: the semantic interoperability, which deals with meaning and relationships of the data, and syntactic interoperability, which deals with the format of the information that is being exchanged and shared. And of course, the last is technical interoperability, that deals with applications and infrastructures that link systems and services, and it basically deals with the biggest problems are so-called fragmented ICT islands. The legacy systems from the past need to be updated so that they can freely communicate on a technical level. Very short note about information immunization information systems. Those are the systems that are confidential, population-based, computerized, that record, store, and provide access to consolidated individual immunization information. They are used in planning the vaccine schedules and also responding in a timely manner to what we are seeing now, basically pandemics, epidemics, and also maintaining the level of vaccine coverage on a good level. When we talk about the interoperability, I would just like to note that if any of you have been involved in developing the digital COVID certificate, that is the best example of short-term interoperability, where many systems, including the IISs, had to be linked, in order to gather the data, exchange the data between the countries, form code sheets that are understandable, and then produce the COVID certificate that we now more or less use to travel freely around Europe. This is not the, of course, theme of this meeting, but just a kind of the most fresh example of how interoperability produces a commonly agreed upon goal. So not to waste too much time on theoretical concepts of interoperability, I would like to give a word to our colleague Hanne Dorte, who is going to show you what we have jointly done, and then we can show you basically how what we are talking about needs to look like. Let me just stop my video. Thank you.
Good afternoon. My name is Hanne Dorte, and I'm going to talk about the standardized vaccine coverage estimation that we have done in the EU JAV project. And here interoperability is very important. The aim was to identify measles immunity gaps nationally and across borders. And this really requires that you can have comparable vaccine coverage estimates. To do that, we need to have a standardized algorithm to estimate coverage. We need to have standardized data extraction, so data are comparable between the databases. Extraction of coverage data at the same point in time across databases, or else you cannot compare it. And if you want to act on it, real-time data is really preferable. To make sure that we had a standardized vaccine coverage estimation, we decided to develop an R package, which is a kind of a statistical tool. So we were sure that it was done in the same way in all the countries. So how did we organize it? We decided that it was important that the data extraction and estimation of coverage was performed locally. And by that, we mean that the data each country had would not leave the countries, it would stay in the countries. They would estimate coverage locally, and then only the coverage estimates were transferred to a public platform. So to visualize it, if you look at this orange line that we have here in the middle of the screen, everything above is going on locally, and what is below the orange line, this is what is happening on the platform. So we shared protocols so that the countries could estimate coverage and extract data in a standardized way. They downloaded an R package, ran through the R package these standardized data sets, and the output, then they got an output that was available locally on their computers, and also there was output like coverage estimates. So 85% of birth cohort 2012 were vaccinated with dose 1, for instance. And this was the output that was transferred to the platform. And these estimates, they were put together so that we could make this maps and graphs on the platform. But before we do this, we have to agree on how to estimate coverage, and we decided to use a period prevalence, and then we will estimate coverage by birth cohort. This is a traditional way to do it, so it is a number of children in each birth cohort that is registered in the immunization information system, and that is vaccinated with a measles-containing vaccine dose. And this is divided by the total number of children in the birth cohort. So you get the proportion of children in each birth cohort that is vaccinated. That will generate a map like the one you have on the top here of Denmark, where in each region, the color represent the proportion of children that is being vaccinated. The other but this coverage, it tells you that you have a certain level of coverage, but it doesn't tell you anything about if there's any delay in coverage. So we decided also to estimate coverage by 18 months. And by this, you will create lines like you can see in the lower figure here at the left, at the right-hand side of the slide. So we create one line per birth cohort. So at the x-axis, you have the age in months of the birth cohort. At the y-axis, you will have the percentage or the coverage percentage. So what you do is that you say, okay, at 12 months, when the children is 12 months of age in a birth cohort, how many is actually vaccinated? When they're 13 months of age, how many is vaccinated? And then you plot these estimates, and you can see that your coverage will increase over time because children is getting vaccinated when they reach the recommended age. If these lines are on top of each other, it means that the coverage or the vaccination takes place pretty much at the same age in all the birth cohorts. If there's differences, it means that you will have there's some delay in coverage somewhere. You can also see from the lines here that there is when the children receive the doses, there's different in what coverage they end up with. So here in Denmark, there's a tendency that it is the youngest cohorts that has the highest coverage. Okay, when you want to do immunization information gaps or look at that, it is important to be aware of the vaccine schedules among in Europe. And I have listed here the schedules for the JAV partners. This is downloaded from the ECDC homepage in November 2020, so almost a year ago. The red box here is the recommended age of dose 1, and the purple one is the recommended age of dose 2. So dose 1 is mainly given between 12 and 15 months of age, while the second dose is administered between 16 to 18 months and until 12 years. And you can already see here that just these coverage or these vaccination schedules will create immunity gaps. There was 3 countries who participated in this exercise by extracting data for the coverage estimation. It was Finland, the Netherlands, and then Denmark. All countries provided at least 3 data extracts, and in November and December 2020, all countries extracted data. So these data from these 2 months is directly comparable. So now you can see here the output of the R packets. So Finland, this is Finland, as you can see, and they ran the coverage estimates in March, November, and December. The recommended age of vaccination for measles containing vaccine dose 1 is 12 months in Finland. So in March, so if we're looking at data in 2020, it will be the birth cohort from 2019 that is getting vaccinated. So in March 2020, you can say there is low coverage in birth cohort 2019 for dose 1, which is expected because not that many children has reached 12 months of age. And here I have to tell you that the red colors here is the low coverage. So dark red is 0. And then we move towards yellow, green, blue, and the highest coverage is when you have purple colors. So we do not expect high coverage in March because very few children has turned 1 year of age or 12 months of age. But when we move towards November and December, you can see that coverage is increasing. And you can also see that there's differences between the regions. You can see from November till December that the coverage is improving because that you get more dark green colors. So this is the output, the local output that the countries have when they run the R packets. So they can actually see the data that have extracted and what is the result of that. If we take another example, this is from the Netherlands. The recommended age of vaccination here for measles containing vaccine dose 2 is 9 years of age. So in 2020, it is birth cohort 2011 that is turning 9 years. So this is the one we're looking at here. They extracted data in September, November, and December. What you can see here is a little surprising because there is quite low coverage in September, and you would expect to have a higher coverage because there's quite a lot of the children that has now turned 9 years of age. There's also quite a lot of difference in the different regions. When you move to November, there's an improvement in coverage, but still there are colors from red, which is 0, until green, which is 70 to 80%. And then there's quite an improvement until December. So we had to figure out what is going on in the Netherlands during this autumn 2020. Therefore, it was very convenient to have the coverage by ages and months. And here you can see all the older birth cohorts that are older than 2011. They are the lines here on top of each other. But then the green line here, that is the birth cohort 2011. They are getting vaccinated later than the others. And this was what we could actually see on the maps. So when you move towards November and December, this green line is increasing quite steeply. So coverage is catching up. And we asked the Netherlands, and they explained to us that MCV dose 2 was postponed due to COVID-19. So this is why you have the low coverage in September 2020. And it was also decided to resume during autumn. So this is the reason for this steep increase. And I think this coverage by ages and months shows this delay in coverage very nicely. Okay, now I've explained the national data. Now, one of the purposes was also to compare cross borders. This is still the output from the R package. So Finland and Netherlands, they sent me their maps so that I could look at and compare the different compare across borders. These data are extracted beginning of December 2020. So I extracted at exactly the same point in time. And you can see just from the colors that there are differences between the coverage in these three countries. So this is 2019 dose 1. So the highest coverage is in Finland, where the recommended age of vaccination is 12 months. It is a little lower in Netherlands, where the recommended age is 14 months, and the lowest is in Denmark, where the recommended age is 15 months. So you can see that the differences in recommended age of vaccination creates immunity gaps. Another example is MCV dose 2, where we expect even larger differences. And I have here put 2 rows of maps. The top one is birth cohort 2014. Below it's birth cohort 2016. And here you can see the recommended age of vaccination is 6 years, 9 years, and 4 years in the 3 countries. And there's a huge difference in coverage between these countries. At the same point, again, these data are extracted at the same point in time in beginning of December 2020. So altogether, this we can say that the R package, they allow us to estimate coverage in a standardized way, and we can compare the coverage between the countries, and we can identify delay in vaccination. The electronic registers are very convenient because they allow us to extract data real time. And I can say from this exercise, the countries were able to extract data within a few days. And by that, we could identify the actual immunity gaps in coverage. But of course, there are other reasons for immunity gaps. But this is to illustrate that at least the recommended age of vaccination, you have to take that into account before you start talking about other reasons for immunity gaps. Now I have presented what the R package output is. So now my colleague from Croatia will show you what it looks like on the platform. So the floor is yours.
Thank you. Let me just share the screen. Okay, is that on share? Okay. I hope you can all see it. So as you can see by the lorem ipsum, it is still under the development, but the core functionalities that Hanne Dorte has presented are still here. So we have 3 main tabs that are informing about the vaccine coverages, countries, coverage in Europe, and coverage in age. If we look at the countries, we have on the platform data from Netherlands and Denmark. And if we look at the Denmark, we can see types of graphs that can be used with the filters, and also with the slider for the status date of uploaded data. So Denmark has uploaded 4 data sets, which are presented here. They're a little bit small, but if we look at here, we can see the data for Denmark in general, or for NUTS levels that they have uploaded to. So if we look at the, I'm not going to butcher Danish, so Nordirland, probably, sorry, then we will see only the data for that region. And if we slide on the data points, we will see the changes in graphs depending on when the data was extracted. And here are, of course, the years for vaccination coverage. This is dose MCV1. The same thing is here. The only difference is that we have a map and we have a filter for birth cohort. So if we take a birth cohort, let's say 2018, MCV dose 1, Denmark vaccinates in the month, let me just check, I have here, in the month 15. So we can see here the data for every region of the Denmark. It changes if you slide with the mouse over it. If we change the data sets, colors change depending on when the data sets were extracted. Of course, same goes for the MCV2. This is for the years, again, regions, and MCV dose 2 map also. If we take, so Denmark vaccinates children with the second dose on the 4th year of their lives. So if we take 2015, we are going to see that whole Denmark basically had vaccinated children because they have reached the age of 4. But if we take a look at 2016, we see that there's a different colors, and if we change the slider for data point entries, the colors will change depending on what the vaccination coverage was. Hanne Dorte also mentioned that we have graphs for the birth years. I'm going to make this a little bit bigger so that you can see. So we can basically, depending on which birth years have been uploaded, we can limit the birth years. Let's say that we are going to limit from 2009 to 2021, and the status date will remain the same. And here on the x-axis we have age in months, and on the y-axis we have percent of the children that have been vaccinated. As she has explained the curves, but we have added a kind of a additional thing here. If you slide over the lines, you can see by the year what the percentage of vaccinated children was based on the age in months. So if you move more and more and more, you can see that the percentages go up. Same goes for the MCV dose 2. And that is basically the information on the countries. Of course, as Hanne Dorte has mentioned, all of those graphs depend on knowledge about the vaccine schedule. So we will definitely have a link at every possible place in the platform where people can inform themselves about the vaccination schedules of a specific country. When we talk about the coverage in Europe, we have here the map of Europe, which then informs people about the coverage of the birth cohorts based on the NUTS 2 level, if I'm not mistaken. And here we have the data from Netherlands and Denmark. And as Hanne Dorte has shown in parallel graphs, we think that this is actually one of the most strongest points of the platform, because it shows not only the data from one country, but from many of them on the regional levels. And you can also see, unfortunately, Netherlands and Denmark are not so close. But if we take a look at the birth cohort 2011 that Hanne Dorte has shown, we see that MCV1, let me just pull this up a little bit. You can also slide here, it shows the percentages. We can see that the majority of children have been vaccinated because the difference between Netherlands and Denmark is basically in 1 month of age. Denmark vaccinates on the 15th month of age and Netherlands on 14th. But if we take a look at the coverage in Europe for MCV2, we are going to see that birth cohort 2011 looks a little bit differently. Let me just pull this up a little bit. As Hanne Dorte has shown, we see that the coverage in Netherlands is picking up, but it's not on the level that you would expect from the previous years. If we see 2010, we see that the coverage is pretty high. So something must have happened in 2020 in order to delay the vaccination of birth cohort from 2011. If you look at 2012, Netherlands is almost red, while Denmark is in the blues, which is basically a good vaccination coverage. But you need to understand that, as Hanne Dorte has pointed out, that Denmark vaccinates children on 4 years of age and Netherlands at 9 years of age. Also, we have the third tab, coverage on age, which deals in kind of a general vaccination of, and if we look at the 2011 birth cohort, we see that Netherlands has 96 point, or basically 97 percent of kids vaccinated, and Denmark 88. If we look at the MCV2 birth cohort 2011, we see that I have misclicked something, but just see something here. Where is there? We see, oh my God. Unfortunately, we didn't center the map still because, well, there are territories that are far away from Europe geographically, so it takes all of them into an account. So basically the same thing. It calculates the general vaccine coverage of countries. And here we can also see age in months. So if we shift, the colors will change. So there we go. I hope I'm trying to be a little bit fast so that our colleague Sarah has a little bit more time. As I said, this is still work in progress, but main functionalities are here. And by the end of the calendar year, we should have a fully functional platform so that people can use it. That's it from me. Thank you. Over to Sarah.
Okay, I'm going to share my screen then. Hold on a second. Okay, hope that everyone can see that.
Perfect.
Good morning, everybody. I'm going to present very briefly about the feasibility study for EU-wide campaigns. So it's really useful, everything that Hanne Dorte and Julian have presented there, to be able to identify regions in Europe with lower vaccination coverage. But I think in order to be able to design a campaign to address that low coverage, you need to also have an understanding of how the program is being organized, as well as what might be the reasons behind the lower coverage. And so we've been working with the work package 5, but also very closely with the work package 8 on vaccine hesitancy, in order to understand what can be the benefits of teaming up across borders, and what you can gain by teaming up. And so what we have done is we started off at the Rome General Assembly a couple of years ago, having a workshop with all of the members of the EU JAV from different countries, in order to brainstorm a little bit on the why what is the motivation for people to work across borders. I'll just go to the next slide. Here, this slide summarizes kind of the main themes that we discussed at that workshop around the why. And if I just go through them, we talked about sharing expertise and training of healthcare workers. We talked about adult vaccination. There's a lot of new vaccinations coming online. Many countries have vaccination programs that are designed for children. But there's a lot of work to do now also with adult vaccination more and more. We talked about vaccine acceptance, and what we see is in terms of vaccine acceptance, vaccine confidence, complacency and convenience, there are many similar trends in different European countries where it can be useful to collaborate. In-school campaigns can be something that can be useful to work on together with a common target audience. Also, in all EU countries, there are various different migrant populations, which may have some commonalities, and so it can be useful to share information and inspire each other. And I think we've seen this particularly in the context of the COVID pandemic and COVID vaccine, that there is this need for consistent messaging at least a basic level, because if countries are saying, national public health authorities are saying different things about the same vaccinations, then that can be very confusing. So that's a summary of some of the reasons why it can be very beneficial to work across borders on EU-wide vaccination campaigns. And then what we were able to do with Work Package 8 is add in a few questions to their big survey on vaccine hesitancy about work that has already been done across borders in this area. And here is just a snapshot of some of the results of that survey. The first map is about interventions. So have any interventions to address barriers of drivers of vaccination been done as a collaboration with cross-border partners? And here you can see in blue the countries that responded in the positive, that they have done work in this area across borders. And the second map is the responses to a question about studies. So have studies to barriers and drivers of vaccination, including literature reviews and data sharing, been done between cross-border partners. And there you can see that there are a few more countries that have indeed done some cross-border work in that area. So I think what you can conclude from that is that there is already quite a significant amount of work that's been done across borders. And in the results of the survey, we actually see what has been driving those initiatives. And we can also see from the outcome of the workshop in Rome that there is a willingness and indeed a wish to work across borders on some issues. And so in the next couple of months, in November and December, we're going to be having a new series of regional workshops to discuss all of these issues and the results of the big survey, and take into account the context of COVID vaccination and how the situation has changed over the last couple of years, to discuss again what can be gained by teaming up, what's already being done across borders, and what type of EU support is needed to facilitate more cross-border actions in this area. And then we will hope to publish a final report in the first quarter of 2022. Thank you.
Thank you, Sarah. Thank you, Serdan, and thank you, Anne-Dorthe. I can't wait to see the full platform with all the countries in different colors, and also to see the report regarding the trans-border vaccination. Now we will go through the Work Package 6 with Antonietta Filia and Karian Johansen. We can see both of you at the moment.
Good morning, everyone. I'm happy to be here today to present our work in the EU Joint Action on Vaccination. I will just share my screen.
Okay, perfect.
Okay, so my name is Antonietta Figlia. I'm a public health physician and researcher at the Istituto Superiore di Sanità in Italy. That's the Italian National Health Institute. And in the EU JAV, I am leading work package 6 on vaccine supply and preparedness, together with Karianne Johansen from the Norwegian Institute of Public Health. So in today's presentation, I will introduce the rationale and aims of this work package, and then describe our activities at the ISS. And following this, Karianne will go on to describe the activities that she is leading with her team. As we all know, vaccination is one of the most significant public health achievements and has led to the control or elimination of many serious and even deadly infectious diseases. However, national immunization programs depend on an adequate supply of vaccines in order to function properly and to achieve the set objectives of the program, as also recently seen during the COVID-19 vaccination campaign. Many countries are facing challenges in securing an adequate supply of vaccines, and vaccine shortages and in general drug shortages have been reported globally in recent years, including in countries of all income levels. Vaccine shortages are a serious public health issue since they can lead to missed opportunities for vaccination and greater risk of occurrence of deadly vaccine-preventable diseases. So there was a need to understand the entity of the problem of vaccine shortages in the EU EEA and to reinforce mechanisms of vaccine supply, forecasting, procurement, and stockpile management. So the aims of this work package are to define the basic principles for vaccine demand planning and forecasting, and to reinforce mechanisms of management of vaccine supply. The work package is divided into 2 major tasks. The first task is mapping vaccine needs and demand, and it's being led by myself and the Italian team. The Italian team is made up of experts at the ISS and also 2 regional Italian regional health authorities. We have in this task, we have 3 deliverables, which are the 3 reports which we see listed here on this slide. And we have already prepared 2 reports, and I will present these to you in more detail in the following slides. The first report is a report on previous experiences with vaccine shortages in EU EEA countries and non-EU partners of the EU JAV, and responses at national and European levels. And the second report is a report on financial mechanisms for vaccine procurement. The final report will be a report on guidelines on procedures to estimate vaccine needs and demand and procurement. And this is the final report which we are currently working on. The 2 reports are available on the EU JAV website. And following this, Karianne will speak to you more about the deliverables of the second task. So before going on, I would like to highlight that this work was done prior to the availability of COVID-19 vaccines. So it is focused on other vaccines included in the national immunization programs. So this is the first report we prepared on previous experiences with vaccine shortages. And from February to May 2019, we conducted a survey amongst persons in charge of immunization programs or of vaccine supply and procurement in EU, EEA countries to collect information on vaccine shortages that had occurred in the previous 3 years. So 21 countries of 28, 21 of 28 invited countries responded and participated in the survey, and of which 19 reported at least one shortage, for a total of 115 shortage or stockout events in the 3 years considered. The number of shortages and stockouts, their causes, and the impact on the population varied between countries. However, almost all countries reported at least one shortage during the 3 years. And the figure on the right shows in dark green the countries that reported the greatest number of shortages and stockouts. Italy and Greece were the 2 countries that reported most of shortage stockout events, followed by France and Latvia. The median number of shortages per country was 5, with a range of 0 to 15, and the median duration of each shortage was 5 months, although 19% of the 115 shortages lasted over 2 years. And at the time of the survey, there were ongoing shortages in 6 countries. So we can see from these results that vaccine shortages are a relevant public health problem in the EU EEA. In this slide, we can see the vaccines which were most frequently affected by shortages and the main causes. So the vaccines most frequently affected by the shortages in the 3-year study period were diphtheria, tetanus containing vaccines, or DT containing vaccines, followed by hepatitis B, BCG, and hepatitis A vaccines. DT containing vaccines accounted for 25% of shortages in 14 countries. And most of these shortages were due to a global shortage, in particular of the acellular pertussis component, which has a small supplier base. Hepatitis B and A vaccines were respectively the 2nd and 4th most frequently affected vaccines. And most shortages of these vaccines were due to global shortage. BCG accounted for 10% of reported shortages in 11 countries. These are the main cause for these shortages. The main cause was a global shortage since due to production problems of one large supplier and a limited number of manufacturers with authorized products. Overall, the most commonly reported causes of shortages during the study period were production issues and global shortage, which accounted for respectively for 34% and 30% of shortages. Regarding production issues, it is well known that vaccine production is very complex, and with respect to other manufactured drugs. And because of the complexity of vaccine production and the long lead times, production capacity cannot be increased quickly, leading to insufficient availability of vaccine doses if any problem occurs. In regard to global shortage, this can be the result of various interrelated factors, including the lack of raw materials or a limited supplier base. Finally, higher than expected demand due to changes to vaccine schedule or to targeted groups or inaccurate forecasts accounted for another 15% of shortages. This points to the need for accurate forecasts and timely communication between public health authorities, NITAGs, and manufacturers. Unexpected shortages or upcoming changes to the vaccine schedules or to targeted groups. So conclusion, we can say that causes of vaccine shortages in the EUA are complex and multifaceted, and they vary by product and country, and include supply, demand, and information issues. We explored also other areas in the survey, which I won't go into detail for lack of time here, but we also explored actions taken by the countries to address the vaccine shortages and some issues that were encountered, vaccine procurement and purchase mechanisms used, stockpiling, needs estimation, how this is done, whether there is any domestic production of vaccines, whether the countries have an immunization supply plan or procedures to address shortages. And we also asked about shortages and stockouts of other biological products, such as diphtheria antitoxin or immunoglobulins. Here in this slide, I will just indicate some other interesting findings of the survey. We saw that vaccine shortages had a relevant impact on vaccine services in terms of changes to the vaccination schedule and also in terms of time resources spent to find adequate solutions to mitigate the shortages. For example, 23 of 115 shortages led to a disruption in immunization services. And in 9 countries who experienced a shortage of DT-containing vaccines had to change their immunization programs to mitigate the impact of the shortage. We also found that only about half of participating countries have recommendations or procedures in place regarding the use of alternative vaccine products or vaccination schedule in case of shortages. And these are important so that countries are ready to make recommendations in a timely manner to mitigate the shortages should they occur. Finally, we also collected stakeholder views on the most relevant problems leading to the shortages, on what is being done and on what should be done to avoid or mitigate shortages. And we interviewed Vaccines Europe and the European Medicines Agency. So their views are also included in the report. And one of the conclusions of the report is that coordinated actions are needed from all stakeholders to prevent and mitigate vaccine shortages, including timely communication between supply and demand, which is fundamental to avoid and mitigate shortages. This report is, as I already said, it is available on the EU JAV website. Our second report is one on financial mechanisms for vaccine procurement, based on a survey among EUEA and EU JAV consortium member states. This report includes key concepts of vaccine procurement from the literature, including advantages and disadvantages of self-procurement versus centralized vaccine procurement methods. And it includes the results of a survey, of a second survey, to collect information on local financial mechanisms for vaccine procurement used, the experiences of member states, and opinions on joint procurement of vaccines and other forms of cross-border collaboration. In this slide, I show the main findings of the survey, which are included in the report. We found that in EU-EEA, vaccines included in the national vaccination schedules are entirely funded by the national or subnational government in the majority of countries. Most countries use annual, not long-term budget planning cycles, mostly centralized. And overall countries report being satisfied with their procurement process. However, most countries report using price criteria, which may be a disincentive for manufacturers to participate in tenders and invest in research and development. The majority of participants reported being favorable to joint procurement of vaccines during serious cross-border health threats caused by vaccine-preventable diseases. For example, as was done during the COVID-19 pandemic. and other forms of cross-border collaboration, such as sharing vaccine prices and other market information, or lending of vaccine doses in case of vaccine shortages, have been used in the EU. So in conclusion, I would like to highlight the added value of the activities carried out in this work package. I can hear some voices. So first of all, a comprehensive view of vaccine shortages and stockouts experienced in EUEA, their impact on vaccine services and their main causes, as well as the financial mechanisms used for procurement in the EUEA was missing. Public health strategies to assure a stable and adequate vaccine supply for immunization programs are identified in this report. And we also gave some recommendations for preventing or mitigating vaccine shortages, including the stakeholder views. And also the experiences and opinions of member states on joint procurement of vaccines and other form of cross-border collaboration, and identifying the main strengths and weaknesses of current procurement and financial mechanisms may serve as a basis for identifying ways to strengthen vaccine supply and cooperation between member states. In our next and final report, we will capitalize on existing initiatives and best practices and define procedures and methods to estimate vaccine needs and procurement in the member states in the short and long term, including defining common basic principles for vaccine demand forecasting. I will now give the floor to Karianne from the Norwegian Institute of Public Health. She will talk to you about the activities to reinforce mechanisms of management of vaccine supply. Over.
Yeah, many thanks. So Antonetta, you will then just share the slides. So the second part of this work package has been to look into mechanisms of management of vaccine supply. And this has been a work we've done in the Norwegian Institute of Public Health and together with the partners of the joint action. But we've also worked together with Italy and Antonetta. So next slide, please. And our main task has been during 2019, before the COVID-19 pandemic, was really two key tasks. We wanted to understand the JAV partners, what they thought about mechanisms to ensure sufficient supply. Could you have the full screen, please?
Sorry.
Yeah. And secondly, we also wanted to understand the partners' opinion if they wanted to share data on vaccine supply and demand among each other. So we had a report which it's on the Joint Action's webpage, and the detail you can find there. We updated the report in January 2020, where we looked more in depth into different concepts for sharing European data on vaccine demand. Next slide, please. So on the first topic, when we asked about opinions on key mechanisms to ensure sufficient supply for immunization programs, the countries responded that an early warning system from suppliers and manufacturers of potential stockouts should be in place. And they also said that sufficient stockpiles of vaccines at national level had to be in place. And also they recommended the use of an emergency stockpile. And a comprehensive national overview of vaccine demand and stocks was needed. And this reflects back to what the European Commission said earlier, that it's really the member states' responsibility to ensure sufficient supply for vaccines. The next slide, please. And then when, in case member states, if you experience a shortage, we also wanted to understand what were the recommended mechanisms to better able to exchange vaccines between the member states. And the feedback they gave was that they wanted to really have a rapid exchange mechanisms on available vaccines. And also they saw the need to harmonize labeling of vaccines in the European Union. We also wanted to understand their opinion on data sharing, to have a European data repository, and interesting, only 4 countries or 4 of the respondents said that this was a recommended mechanism. But liability protection was also important for them. Next slide. So when we asked about their willingness to share data on vaccine supply and demand, and if it would really prevent shortages in European Union, as I said earlier, they were uncertain about the need and options for to have a full data repository. But on the other hand, they also responded that if such a tool was needed, it should be really focused on rarely used immunoglobulins and antitoxins, but also emergent infectious disease vaccines or vaccines to be used during epidemic outbreaks. And they also gave some specific examples, and these were before the COVID-19 pandemic. Next slide, please. So we also wanted to understand further on if the member states wanted to exchange data, what was the options and what could be the tools to help them to do so. And we focused on 3 options, which we are going to explore further during the work package. And the first was the voluntary sharing or the rapid exchange mechanism on available vaccines using the early warning and response system through the Health Security Committee. We also wanted to understand if they were willing to share data among the regional in a more regional context, like to have a regional virtual stockpile or a full-blown European data warehouse. And during 2019, there has been ongoing discussions between the European member states and the Health Security Committee on this rapid exchange mechanism. And there have also been thoughts around development of functioning standard operation procedures to simplify exchange of vaccine supply, and also to have necessary templates for liability and etc. And it was proposed from their side that in order to implement these SOPs, they should first test them by organizing an exercise through the European early warning system. There have also been other discussions on a tender to identify options for physical stockpiling of vaccines in the European Union. And now, of course, the HERA initiative is very interesting in terms of vaccines for emerging infectious diseases. Next slide. So what we have started to work on these different concepts is to look first into the basic, to have a voluntary sharing or rapid exchange mechanism on vaccines. And we believe there is a need to really agree on the functionality, but also the scope of such an exchange mechanism, and also the implementation risks. And then this tool could be further developed or explored further through a regional virtual stockpile or a full-blown European data warehouse. But we believe that this needs to be a lot of continued work on this, and we have only managed to do high-level analysis on these different options. The next slide. This is just to describe that we have done concept descriptions and templates, and these needs to be further developed, which we will look into more in depth during our work with the joint action. Next slide. So what is our added value of this work? We really think that a better understanding of important mechanisms to ensure sufficient supply and stockpiles, and also the sustainability was needed. We thought there was uncertainties of the member states' opinion on the need to share data on supply and for which types of vaccines. And our analysis has identified 3 future options that we believe need further in-depth analysis to enable exchange of data on vaccine supply and demand between the member states. And it really seemed that vaccines to be used during an epidemic outbreak and vaccines for emerging infectious diseases would be the most important focus area for a future European data repository. So we will now prepare a final report and recommendations of our key results from task 6.1 and 6.2. Many thanks.
Thank you, Antonietta, and thank you, Carrie-Anne, for the presentation. And now we will move to the following work package, which is work package 7, and with a speaker, which is with Marie-Paul Kieny. Your microphone is off.
Yes.
Okay.
Yes. Hello. Can you hear me?
Perfectly.
Absolutely. Just give me 1 second because the noise has started behind me. Jana, non, pas maintenant. Jana, pas maintenant. Merci. Apology. It was exactly the moment when I started to speak. My apologies for that. So let me start with a presentation. So what I will present today is the current status for work package 7. So, and I present on behalf of Jean-Daniel Lelière, who's the leader for work package, for task 7, of work package 7, task 1, determining priorities for vaccine research, and of Carrie-Anne Johansson, who has just spoken on work package 6, who has been the main actor on working on potential mechanisms to increase collaboration of funding and research cooperation. So the overall work package 7 is about addressing specific objective 4 of the EU joint action on vaccination, which is to define tools and methods for vaccine research priority setting. How do you decide what should be the priority, and to identify mechanisms to increase cooperation between member states, and in particular for funding these priorities. So let me first review the result and the status of task 1. So this is work package 7.1, determining priorities for vaccine research. So indeed, in terms of background, as we all know, the research funding system in Europe is very complex with many actors. And nevertheless, in the context of limited resources, prioritizing research question is clearly needed because you want to fund those who are likely to have the most impact. So it is therefore necessary to develop a methodology which is transparent, evidence-based, following the best practices to define health research priorities in the field of vaccination in Europe. So why did we have to work on a new methodology? Is because actually it is not anymore state of the art to only rely on expert advice, because expert can be biased, and the idea is to have a method that is as much as possible removing individual biases and can be reproducible. So the process focuses on public health research aiming at improving vaccination coverage in EU member states, because this is the overall objective of this of a joint action. So in terms of methodology, the team reviewed the literature on the various methodology and interviewed experts, and finally decided to use and to further develop, adapt to the purpose of work package 7, a methodology which is inspired by the Child Health and Nutrition Research Initiative, which was initially developed by Ruden, which is a multi-criteria decision analysis methodologies. So these are the various steps. You first have to select the managers of a process. Then you define the scope. What is it that you want to prioritize? You define which are the research questions that you want to prioritize. Then you choose the criteria. You have a transparent process to choose the criteria for the selection, for the prioritization. These criteria are then weighted, and finally, the potential objects to be prioritized, which are the research question, are scored using the weighted criteria. So in order to have a process which would be with as little biases as possible, the experts who are tasked to do the various steps of the selection process, which is choice of criteria, weighting of criteria, and ranking of the research options using this criteria, these experts are independent and there are different group of experts performing these 3 tasks. So in terms of a research question that were gathered, the scope of the process was to gather and to ask all the community to propose research question, focusing on public health research aiming at improving vaccination coverage and not on the development of new vaccines. So the question were not, what's the priority of developing a new vaccine against respiratory syncytial virus, for example. This was out of scope. But what would be, what is the best use of social media, for example, to increase vaccination coverage could be one of the questions that would be envisaged. Then there was, of course, consideration of epidemiology, human and social science question, as well as implementation research. The question where there was a survey sent to joint action partners, experts and stakeholders. This was done online, and initial list of questions were consolidated by the team. So which were the questions used for prioritization? So we first, the management team, of course, made a proposal to a group of experts, and the group of experts considered these criteria on an online meeting, and these were the 8 questions that remained for the prioritization: answerability, effectiveness, deliverability, disease prevalence or incidence, equity, generalization, territory, and accessibility. So then these criteria were weighted through pairwise comparison. The weighting was performed by 5 experts, again using an online survey, and finally the weighting was discussed, and the final weights were obtained through consensus of the experts involved in this work. So for the scoring then of the research proposal, research question, the scoring was done by another group of experts. It was first done through a web-based survey to collect individual rating, and a final meeting to reach consensus on the priority. So we first ran a pilot process to see whether methodology was robust. So this was done during 2019-20, and we applied the prioritization framework to 4 pilot vaccines: HPV, influenza, measles containing vaccine, and pertussis. We received 124 questions, and 27 were sorted into 3 tiers during a final face-to-face meeting. I will show you briefly the first tier, where 6 questions. The majority of the question prioritized by experts were on influenza vaccine. Of course, remember this was before the pandemic, and its effectiveness. And the priority were sent to the European Commission and widely disseminated to within the scientific community. We have currently a paper, as you can see, published on this work. So these are the 6 top priority emerging from the pilot process. So I don't want to enter into them, but as you can see, they deal with measles and with influenza mainly. So then after having developed a methodology, the team ran a second and final prioritization process during 2020 and 21. So we modified the framework based on the result of a pilot, as expected. We also decided to have a broader consultation to collect research questions, for example, and we removed one of the criteria because it was not well understood by experts. We enlarged the scope to all vaccines used in the EU, with a focus, of course, on COVID-19 vaccines, and the experts reached consensus of 6 top priority, 12 medium priority, and 6 lower priorities. And the majority, as you can expect it, focused on COVID-19 vaccines. So again, I don't want to enter into the detail of this question, but you can look at it further after this call. So in conclusion, what is the added value of this work on task 1 of work package 7? But the EU JAV developed a generalizable and replicable framework to set research priority for vaccination in Europe. And this is the topic of the deliverable 33 report. And the research priority identified have been and will be further broadly disseminated for consideration for funding by EU member states and the Commission. Now coming to the work package 7.2, sorry, this is a typo here, it should read 7.2, potential mechanisms to increase collaboration for funding and research cooperation. So as background, the objectives were based on the need to better understand different organization priorities and EU member state use of various financing mechanisms for vaccine and vaccination research. The team reviewed joint and collaborative EU funding mechanism in order to understand the opinions on mechanism to fund and collaborate on shared funding for common priorities for research in vaccination in EU member states. So the survey was conducted, directed towards national research organizations. There was a lot, of course, of literature review. And during 2020, there was a short review in addition of the mechanism for EU funding for COVID vaccine, because this was, of course, very topical, and a review of a potential use of new EU instrument for this purpose. Finally, in autumn 21, the report on potential mechanisms to increase collaboration on vaccine and vaccination research was prepared and is now available. So what are the main findings that the team got from national research organization? We got confirmation that indeed EU funding mechanism and collaboration in vaccine research and development are very fragmented and complex, and that funding of research and development as well as of vaccination research is not evenly distributed among the value chain. So the key focus area for funding are in general research and development, basic research, and preclinical development. In some organizations, the financing focuses on influenza, pandemic flu, or HPV, but very few organizations support research for other vaccines like measles, mumps, rubella, or pertussis. Some wish to prioritize funding on emerging diseases for vaccine to be used during epidemic outbreaks. Some others prefer to prioritize funding on specific vaccine in the vaccination schedule to obtain more data on safety, like for example on influenza, which is also a vaccine that needs to be improved in its effectiveness, as we all know. So in terms of cooperation mechanisms between national research organizations, the team found that the most frequently used mechanisms were joint calls or bilateral and multilateral cooperation. The mechanism most likely to increase cooperation could come forward through clear guidance and option for collaboration that would be built into the governance system. A joint evaluation and selection process must be put in place, and there needs also to be sufficient lead time to approve and agree on topics for call for proposal, because you need to have many organizations agree and sign off on this call for proposal. And finally, there is a need for alignment of financial rules. So what seems to be the most promising options for potential future joint European mechanism? Well, as you see here, less than half of the organization believe that a potential future joint European mechanism for like a GPA would increase collaborative efforts. And the area most often mentioned as a particular need is late stage phase of clinical development for phase 3 in particular, and for phase 4 clinical trial. So in addition, many multilateral organizations have been and are very active in financing vaccine research, especially for COVID, of course, as we all know. And several multilateral organizations receive funding from the EU member states or are in very active stage of financing vaccine R&D. So among those, I would like to mention IMI, an European instrument, which will be continued under IHI, the Collaboration for Epidemic Preparedness Innovation, also known as CEPI, who had a major contribution during the COVID pandemic. The UK Vaccine Network, the Global Alliance for Vaccine and Immunization, or Gavi, the Bill and Melinda Gates Foundation, and Wellcome Trust all contributed enormously to research on vaccine during the pandemic. Some EU member states use official development assistant, ODA, financing for this purpose. And unfortunately, these investments are often neither aligned on the EU joint action strategy, nor on public health strategy from EU member states' ministries of health, because the money comes from development and not from health. So could COVID-19 vaccine be a paradigm for joint funding and new EU instruments? So certainly COVID-19 vaccine development was conducted with an unprecedented speed. We all know that. There was massive public funding for the development, direct funding of R&D implementers and for public-private partnership and organization, which is often not the case with public money. And we can see that EU member states have primarily invested in existing pharmaceutical company to ensure regional manufacture. And of course, the Commission and EU member states were instrumental in ensuring that sufficient vaccine supplies were available for member states through so-called APAs. So there are plans underway for the implementation of what is known as HERA, which is the Health Emergency and Preparedness and Response Authority, in order to strengthen Europe's ability in this area to ensure the development, but also manufacturing, procurement, and equitable of key medical countermeasures like vaccines, but not only. HERA will also promote research and innovation to develop effective and affordable countermeasures of all kinds, and especially vaccine, of course. And HERA will also coordinate EU health security before and during crisis. So clearly, HERA is being seen as a major development for vaccine and vaccination research and implementation in European member states. So in conclusion, what's the added value of this work? It led to a better understanding of different organization priorities and of EU member states' use of financing mechanisms for vaccine and vaccination research. They have confirmed, of course, the fragmented and complex funding landscape, and this work also allows us to put on the table the fact that the development of COVID-19 vaccine might be considered as a paradigm for joint funding and for the creation of new EU instruments. So finally, my last stage, what's next for Work Package 7? Well, the possibility for funding of EU joint action research priority should be further investigated and explored, and we will work on this for the end of the project. And the team, both task 7.1 and 7.2, will co-produce the final report with recommendation deriving from their key results. Thank you very much.
Okay, thank you, Marie-Paul. Thank you for this presentation. And now we will go to the last work package of our EU JAV Info Day, Work Package 8, with Jonas Sivela and Antonietta Filia.
Yes, hello, this is Jonas. Can you hear me?
Perfectly.
What about the presentation? Are you able to see it?
Yes, we just put it in diaporama in slideshow. Okay, perfect.
Is it better now?
Perfect.
Good. Thanks a lot, and greetings from rainy and cloudy Helsinki. My name is Jonas Sivelä. I work for the Finnish Institute for Health and Welfare, and together with Antonietta Filia from the Italian Public Health Institute, we are both leading Work Package 8 on vaccine hesitancy and will be presenting about Work Package 8. I will start with a general introduction about the work package, and then I will go through the first part of the work that I've been responsible of, and after that Antonietta will talk more in detail about the social media activities we have. So, as has been stated already many times this morning, vaccine hesitancy is something that has been topical, very, very topical for already before the COVID pandemic, and already in 2019 it was declared by WHO as one of the 10 global threats to health. It is something very complex and very, very context specific, but it's also something that we have in the public health field been working with for a long time, especially within the different immunization programs. And there is a lot of knowledge already there. So so there are possibilities, and there is a need to capitalize, so to say, on this existing knowledge. Also, social media is a so-called new player when it comes to communications and how we interact with each other. And when it comes to vaccines, it's sadly often used to spread content expressing vaccine hesitancy and potentially affecting also our real world behavior related to vaccines. So why is the work we have done especially in Work Package 8 important? It is important because we need to understand better what we actually mean when we talk about vaccine hesitancy. What we see working or what we see affecting vaccine hesitancy and uptake in the real world, how we do work with these issues in the field, what possible challenges we have in this work, and what kind of vaccine related conversations are existing in the social media field, what kind of topics should be prioritized in communication, and which influencers are spreading information or maybe more misinformation online, and how can we better develop communication strategies. So in other words, our aim is to increase understanding of vaccine hesitancy and to create tools and ways to share knowledge about hesitancy and uptake, and especially how what kind of work has been conducted to counteract hesitancy and to, of course, strengthen uptake. And also to increase our possibilities to understand and monitor trends in public sentiments and opinions about vaccinations in social media, and there to be able to recognize, detect early signals of related to the lack of confidence, and to identify influencers and to create ways to in practice monitor social media in a better ways. That was the general part of the work and the aims that we have set for our work. Now I will go through more in practice the work in the first part of Work Package 8, called From Research and Practices to Implementation. So in practice, what we started out with was a very, very thorough, and for some maybe also burdensome, data gathering on vaccine hesitancy. It was conducted as a survey, including well, I can't remember, but almost 100 questions, many of which were open-ended. So it really required a lot of all the respondents. The primary target group of this data gathering were firstly the institutions responsible for the national immunization programs in the European countries, but also the EU joint action stakeholders that are active in the field. We were very lucky to have a very high response rate. So out of the 32 countries that were asked to participate, 28 countries responded, and out of the stakeholders, 8 decided to participate in the survey. We are especially happy about the very big number of countries that really put effort on answering the survey. So the survey was very thorough. It touched upon issues such as our understanding of what we talk when we talk about vaccine hesitancy, the situation in the different countries and regions concerning vaccine hesitancy, confidence and uptake, the situation concerning research-based knowledge on the matter, and also how and what we have been working when we have been trying to strengthen confidence and uptake, and also how the work related to the field of vaccine hesitancy and confidence has been organized, and what possible challenges we can identify here, and also knowledge about the stakeholder activities in the field. So I will very shortly highlight some of the results from this data gathering. We have already published the final report of this part of the work. It can be found on the EU Joint Action and Vaccination website.
Jonas, excuse me, suddenly the sound is very bad and with a lot of echo. Did you modify something on your device or?
No.
Okay, maybe Pavlos, the host of the meeting, can do something. Everything was perfect until 30 seconds ago.
Oh, I'm sorry.
No, it's okay.
Can you hear me better now?
There are still a lot of parasites on your voice.
That's a shame. That's a shame.
But it's better. It's better now. It's better now. Let's go.
Okay. So maybe if I keep it in this mode, maybe that
it's perfect. Like this, it's perfect.
Okay, let's go with this mode then. So I will shortly, and please let me know if you have further problems with the sound quality. So I will very shortly highlight some of the results of the survey. And as I said, the final report can be found on the EU JAV website. It's very long, and it's certainly interesting reading for those interested about the topic. So we started out with exploring how the concept of vaccine hesitancy is interpreted among the respondents. And as many of you know, the WHO has coined or defined the term vaccine hesitancy as a complex and context-specific matter varying across time, place, and vaccines, and it's influenced by factors such as complacency, convenience, and confidence. And our results showed that vaccine confidence, or actually the lack of vaccine confidence, is definitely perceived as the most dominating feature of vaccine hesitancy, and the so-called other parts of vaccine hesitancy, convenience of vaccination services, and also complacency or risk perceptions are not considered as important as confidence. We also looked more closely at the determinants as perceived by the countries and the stakeholders, and here too we see that the lack of confidence in vaccine safety and was perceived by both groups as the main determinant of suboptimal vaccine uptake. Also, what's interesting is to see that, for example, specific groups within the population were something that was considered a major determinant behind vaccine uptake. If we go further, we also looked and asked about the activities surrounding vaccine uptake and confidence. And as you see from this picture, communication activities were very common both in the countries and among stakeholders, but also activities somehow related to healthcare workers. And among the countries also, maybe there was more activities more directly focusing on certain vaccines, and also, of course, naturally more cooperation between different government bodies. But a more thorough analysis of both the determinants and the activities can be found in the final report, and I definitely suggest that you will familiarize yourself with that. It's as I said, certainly very interesting reading for many. Working with vaccine hesitancy is still, I would say, a quite new field for many, and therefore we wanted to also examine or explore and ask how the countries and the stakeholders perceive, or do they perceive any kind of challenges, and are they able to work with these issues in a way that meets their needs. And as you can see from the map, the red countries said no, and these countries said that they're not able to work with vaccine hesitancy and uptake in a way that meets their needs. And this is, of course, very, very concerning. And we also looked at the reasons behind this, and as you can see, many of the reasons are organizational, concerning for example, how national immunization programs are historically organized. Is there, for example, room and mandate to work with issues like this? Also, it's a question of funding and resources, but also a question of finding the right kind of people to work in a environment that has been maybe traditionally very dominated by natural scientists and physicians. So our conclusions from this part is that we need still a better understanding of how vaccine hesitancy is defined and understood. It's defined and understood in very, very different ways, which is certainly something that makes the work very much more difficult. Also, it's advised that, or it would be good to have a more general, or if you wish, holistic approach to vaccine hesitancy and uptake, rather than to focus only on vaccine confidence. That seems to be the case right now. We need a better targeting of different population groups, underserved groups, migrant groups, language minorities, etc. There is a certain overlap when it comes to actors and activities in the field. We need much better coordination and collaboration, both on a national and international level. We need to emphasize the importance of vaccine hesitancy and uptake related work in the public health field. We don't have neither long nor short-term plans. We don't have the resources we need. So this is definitely something that needs to be put on top of the list. And there is also a need to promote all kinds of collaboration through sharing experiences and knowledge. So what I just told you about was the first part of the work, focusing on creating a picture of the situation and what has been done. Then the question that should be asked, what do we do with all this information? What's the added value of this work? And one added value is, of course, that we do our best to disseminate and share this knowledge that we have gathered. And for this, we have launched the so-called Vaccine Hesitancy and Uptake Network on the EU Health Policy Platform. It was already launched in May 2020. It includes a lot of information on all kinds of activities, studies, projects, campaigns, somehow related to vaccine hesitancy. It also includes all the answers, responses from the different countries. It includes links to different studies on vaccine hesitancy and uptake. Very simply put it includes a lot of information, and together with the final report, which you can also find on the EU Health Policy Platform on the Vaccine Hesitancy and Uptake Network, they construct a very, very solid base of knowledge in the field. It also has some important technical advantages. We are able to search information within the network using keywords. For example, if you type HPV, all the files that include HPV can be found on the network. We also have the possibility to organize webinars on different topics on the network. So please sign up to the EU Health Policy Platform if you haven't signed up yet, and please find the Vaccine Hesitancy and Uptake Network. At the moment, I'm the administrator of the network, and so if you have any further questions about the contents, or if you would like to contribute in any way, please be in contact with me. Thank you. This was my part of the presentation, and now I will hand over to Antonietta. I changed the mode of the presentation now.
Okay, that's fine. Hello, everyone. Good morning. I'm Antonietta Fivia at the Italian National Health Institute. I'm co-leading Work Package 8 with Jonas. So I will talk to you about the work we are doing on monitoring public vaccine confidence through social media and the web. We are working on this activity in collaboration with, next slide, please. We are working on this activity in collaboration with experts from the Bambin Gesù Children's Hospital in Rome, whom I would like to mention, Drs. Caterina Rizzo and Francesco Gesualdo. The aim of our task is to monitor real-time population sentiment, opinions, and attitudes towards vaccines and vaccination over time and space through social media and other web data sources in order to detect early signals of lowering public confidence towards vaccines, and to identify the most influential online players on vaccine-related topics that can impact the spread of vaccination information on social networks. Next slide. So the work done so far has consisted in designing and developing a vaccine confidence monitoring platform that integrates and allows the visualization of different social media and web data sources. In order to do this, first we defined the objectives and main features for the platform, and we gathered needs, opinions, and suggestions from all the EU JAV partners. For example, which features should be included in the platform, which data should be visualized. We then performed a detailed analysis of the scientific literature to identify previous experiences, benefits, and difficulties related to the analysis of social media. Following this, we defined and validated a list of keywords related to vaccine confidence in 4 languages: Italian, English, French, and Spanish. Through the use of these keywords and natural language processing system, the platform systematically analyzes and presents real-time data from social media and web resources. It extracts topic, sentiment, opinions, and investigates collective behavior on the web. So currently, the platform monitors the following data sources: Twitter, which is an important medium for communication of vaccine sentiments, and is more accessible for research purposes with respect to, for example, Facebook. In recent years, there's been a steady growth in vaccine-related conversations on Twitter. The platform also analyzes the trends on Google searches on the topic of vaccines and the number of clicks on Wikipedia vaccine-related pages. And recently, we have also started analyzing vaccine-related conversations on the social media platform Reddit. The platform gives a real-time indication of the volume of vaccine-related conversations on social media and the other web sources. It detects early signals in events, and it identifies the main online influencers on vaccines. Next slide. So in this slide and the following slides, I will show you some screenshots of the platform dashboard. The dashboard is currently accessible through credentials. In this page, we see the Twitter trend of vaccine-related tweets in a specified time period. Here on the top left-hand side, when you access the platform, you can select the time period of interest and the geographical area of interest, for which there are 4 options. We can either see the pooled tweets or just the tweets from Italy or from France or from Spain. It is possible that other languages could be added in the future. In the graph, the blue bars indicate the daily number of vaccine-related tweets based on the selected and validated keywords, and in the area and time period selected. Next slide. We also created a system to detect early signals of debates occurring on social media and to understand which event sparked the debate. Debates on social networks often explode as a consequence of a specific event. So in brief, this is done by making a time series of the daily tweet count of tweets containing vaccine-related keywords, identifying the median number of tweets and looking at the peaks of the series above the median, then trying to find out which events caused these higher tweet counts by examining the content of the related tweets and the most common hashtags used. Next slide. We can see here this horizontal bar is the median number of tweets on vaccine-related keywords in the specified period. So we see that in certain days, the bars are way above the median. By hovering the mouse over each bar, we can see some extra information on the tweets. So we see the precise number of daily tweets on that specific date, and the most popular hashtags and their daily frequency. Next slide. The platform also displays the most relevant users in the vaccine discourse on Twitter, and several metrics are used to describe the influencers. We see here times retweeted, number of retweets, relevance, most central, closest, page rank. These are metrics used to describe the influencers. Next slide. I won't go into detail on about each of these metrics. Suffice it to say that they allow us to identify the most relevant users and classify them according to how much or how quickly they can influence other users, even those that are not directly connected with them. Next slide. The platform also shows the most retweeted tweets in the selected period and language, and the top Reddit conversations in the selected period. Next slide. Here we see the trends in and the number of clicks on Wikipedia vaccine-related pages, and Google Trends of searches on the topic of vaccines. Next slide. Finally, we are training an artificial intelligence-based algorithm to automatically recognize the vaccine stance of downloaded tweets based on methodology described by the Vaccine Confidence Project. So the tweets are classified as promotional, ambiguous, neutral, or discouraging. So promotional tweets communicate public health benefits or safety of vaccination. They encourage vaccination. They describe risks of not vaccinating and refute claims that vaccines are dangerous. Ambiguous tweets contain indecision, uncertainty on the risks or benefits of vaccination, disapproving and approving information. Neutral tweets contain no elements of uncertainty, promotional, or negative content. They're often statements, for example, factual recommendations about vaccines. And discouraging contain negative attitude or arguments against vaccines, okay, and discourage the use of recommended vaccines. Next, please. So in conclusion, this social media and web monitoring platform is a valuable tool to understand the sentiments and opinions of the public about vaccinations and to detect early signals of lowering public confidence that can then be potentially counteracted through adaptive strategies and then monitored over space and time. This information collected on the platform can be helpful to identify specific topics to be prioritized for communication, to address misinformation, to understand and monitor trends. This type of monitoring also contributes to the analysis of barriers and enablers of vaccine uptake among web users, and allows the identification of vaccine-hesitant communities and even the characterization of subgroup of users. And this can be useful for tailoring interventions to those specific populations. Finally, identifying the influencers on vaccine-related topics, either against or in favor of vaccinations, is relevant since they potentially play a major role in shaping people's opinions and sentiments on this topic. This work can benefit public health authorities and policymakers by providing a better understanding of low vaccine coverage and useful insights to develop and improve overall communication strategies on vaccines and vaccination. It can also inform public health authorities in a timely manner of significant vaccine-related events, especially those that could have a potentially negative effect on public beliefs and behavior, and for which a rapid response could be important, for example, to help decrease the spread of false information. We will produce a report on this work. Ultimately, the goal of this task is to improve understanding of vaccine hesitancy and improve confidence and trust in vaccines throughout Europe. Thank you. Over.
Thank you, Antonietta, and thank you, Jonas, for your presentation, for your work, and the elaboration, among others, of those two very interesting platforms that I hope they will be shared very publicly and very broadly in the coming months. Stelios, would you like to have some last words?
Hello, my name is Stelios Lefkovits. I'm a professional journalist. I'm head of press and communication department of National Public Health Organization, Greece. After all this huge amount of rich and significant information you shared with us today, through the very useful speeches and also all the interesting presentations, it would be pointless for me to talk for 15 minutes just to complete the time I have been given. For this reason, I will be brief and comprehensive, and I promise I will not tire you. Dear Olivier, I want to express my thanks to you, your team, but also to all the speakers, work package leaders, and all the collaborators for your valuable contribution and support in this program. For a fact, COVID-19 has caused significant delays in all activities and consequently in the EU JAV program as well, which on the other hand, precisely because of and through the current pandemic phenomenon, it has become even more relevant regarding the value of vaccines and the value of vaccination in Europe. The results and conclusions of its work package presented to us today are all extremely interesting. A sample of the work done by scientists in Europe and of the simultaneous with the work struggle to form measurable results. It is certain that by extending the program until the end of March 2022, the scientists are given the opportunity to share with us useful results, define conclusions, and valuable recommendations in the field of health. The one and single issue that has a special value, not only in scientific terms, but also from a sociological point of view, and I would additionally say that it has a great interest, even from the journalistic perspective, is that despite the diversity running across the people involved in the program, meaning although we are dealing with multiple and distinct people and daily cultures, and I will point out again that all are important scientists, which in her field of operation, given the 20 different European countries of different languages, different daily habits and balances within their national and local communities, all of them are involved in the program with packages of different thematic units, yet inextricably linked, and work perfectly together for a common goal, for the people of a single Europe, the Europe of a common approach toward vaccination. In order to illustrate the way all the actions of each separate package are connected and all commonly linked to a single approach towards protecting the health of a single, one common Europe, I will quote a series of points I have distinguished, randomly selected from what has been presented without mentioning and disclosing the number of the package. Here's how they are connected. The training programs, vaccines and vaccination, policies in Europe, continuous training in new protocols, raising youth awareness by enhancing knowledge about the value of protecting young people among their communities, which is also a sample of social behavior. The process of sustainability of vaccine value and absolute utility of vaccines. The need for a better understanding of how public health professionals define vaccine hesitancy. Better targeting of population groups, underserved groups, migrant groups, language minorities, etc. The identification of public health strategies to assure a stable and adequate vaccine supply for immunization program, and the structured recommendation for preventing and mitigating vaccine shortages, including stakeholders' view. A better understanding of different organization priorities and of EU MSUs of financing mechanisms for vaccine and vaccination research. Cross-border interventions, studies into vaccine hesitancy, acceptance, responses to JAV, work packages, cross-border questions. It is reasonable, as it was shown through the presentations, that there are also difficulties and delays in the surveys, the campaigns, in the way of exchanging information, and in the result times and deadlines. What we have learned today, I would say, as a journalist for over 35 years, for me, it is of great value. And what we need to keep is that through the energy and scientific goals combined with research and technology, we need to send a message mainly to the media that our home Europe has both the people and the means to build a healthier society of less diseases and the better years of life. Thank you very much. And I hope to next event will be physical. Olivier, the floor is yours again.
Thank you, Stelios, and thank you for your words regarding, yes, the goals, that is the goals of the EU JAV, is to explore and to assess how it is possible in the very near future to have a better collaboration at a European level regarding vaccine and regarding all the axes, all the fields of vaccination. I would like to thank in my turn the Greek team for having hosting us. Again, I would have preferred to have a physical meeting, but it's life. And as you were saying, in the near future, we will have a physical meeting. We were at the end around 100 people connected, apart from the EU JAV member. And so I hope that everybody has very well appreciated the presentation by the work package leaders. And I want to thank them again for what they have presented, from the context of their works to all the work that have been done so far and all the work that will be done in the future. The EU JAV will find its end in March 2022. There will be other deliverables, other studies, better development of platform, and there will be other meetings for us to share with you all that we have, all this, and to secure the fact that all these things will be pursued, will be sustainably disseminated in the future after next spring. So thank you again to all of us, and I'm sure we will see again, but physically, in February or March 2022. Bye, and I think we can put the meeting to an end.